Well, it's now 1 o'clock. Just like last year, I'm still Jim Curran. I'm sorry to have missed the last meeting. I was out of town. I just want to do one housekeeping mechanism. All the panelists will be able to control our own mics and speak. And I would advise us to do a couple things. One is put everything on mute unless you're speaking. And then secondly, raise your hand in the chat area, in the reactions area, and then I can call on you when I see your hand raised, and then you have to unmute yourself to speak. But I think this will allow us to try to get by any technical problems that we've had in the past. So welcome to everybody. Welcome to 2022. I began the end of the year with COVID for my whole family. We had a whole slew of breakthrough infections, ages 1 to my current age. But nobody was really very sick. But I think it's kind of the story of what's happened with this current epidemic of COVID. I'd like to begin by thanking healthcare workers of Georgia and all the public health workers of Georgia and people in the Georgia Department of Public Health who once again have gotten beaten up. And I just want to say something from having a lifetime in public health. You don't go into public health to always get the public to love you, but we've never had anything quite as bad as COVID. I started to think which government official and which government workers at any level have gone away unscathed. And I can't really think of a federal employee who has been a hero or a heroine to everybody. And I can't think of state employees who have been heroes and heroines to everybody, or city employees, or any of their government elected officials. Because basically, you can't be in this to be thanked. And you shouldn't be in it, of course, to be stoned or chased away or criticized or castigated by any government officials. But I think we've never been in a situation where everybody who works in government has been blamed for everything all the time. And the basic enemy here is the virus. Now, that isn't to say that we haven't done a lot of things that could be done better. And testing is something which, got off on a bad start to begin with and has lapsed into problems again. Public policy at every level is criticized. It's very hard to coordinate it. But just think about who we really respect who've been involved. And, at the federal level, the closest thing we have is Tony Fauci, and he's got round-the-clock bodyguards and getting his life threatened all the time and criticized by Congress and lots of others. So if he's the best we can hope for, everyone else has to go to bed thinking, I'm going to get my joys out of knowing I'm doing well, not just because somebody's going to tell me I'm doing well, because nobody's going to tell you you're doing well, except each other. So Kathleen, tell your staff they're doing well. Live there, and thanks to all of you for the great work you do. So the last thing I would say is we are now called to order. We have about 90 attendees listening to us. This is one of the biggest audiences we've had in a long time. And they'll be available, I guess, later on for questions at the end. But Dr. Rodriguez, could you take roll call?
Thank you. Sure will. If you don't mind, remember to unmute your microphone so you could say that you're present. Dr. Curran?
Present.
Dr. Rodriguez, I'm present. Dr. White? Dr. Mercer?
Present.
Major General Carden?
Present.
Dr. Shin?
Present.
Mr. Harper?
Present.
Dr. Cowles? Dr. Cheek? Dr. Curran, we have a quorum, so I'd like to proceed with the approval of the minutes. As you remember, in the last meeting, we had some technical issues, so we were not able to approve the September minutes. So if it's okay with you, I think we'd go ahead and approve both the minutes from September and the minutes from November that were received. At least the ones from November were sent out last week. If there are no objections, if everything seems to be in order, then I would submit them to be approved, Dr. Curran.
Anybody's call for
Second.
it? About the next month.
So moved.
Second. Thank you, Dr. Rodriguez. I think the only last thing I would like to say is that I'd like to thank Norman from our staff and Nancy Stirk, Fanny, and others who are working together to put this together so we could hopefully have a successful event in a timely way. So old business, is that Dr. Toomey? Or is
I
that
think
just-
from old business and new business as well.
Okay, go for it.
Great. And first of all, I wanted to thank you, Dean Curran, for being willing to host this. The last meeting had some IT challenges, to say the least, and the board could hear us, but we couldn't hear the board. And I just really appreciate Nancy and the rest of your team that's been able to help us with that. So many, many thanks. Much appreciated. I want to do something a little bit different. I usually give an overview, but instead, because of what has been happening since we last met, I wanted to actually have some presentations before I close out to kind of give the background of what we've been doing for the last, since Thanksgiving. We were in an unusual situation. I actually knew about Omicron before there was any discussion about it publicly, at least at CDC or even here in the US, because I was contacted by a colleague of mine from Botswana. And so this was even before Thanksgiving. And we knew it was coming. There were some initial reports from news reports, not CDC guidance yet. And I called together my team. It may have even been Thanksgiving Day, Chris. You'll have to remind me. I'm sure your family remembers. And I said, we've got to be prepared for this. We've got to make sure our lab can sequence this. We've got to be ready to doing testing. It's going to come. We don't know when. It's highly transmissible. I think, and I'm just being very straightforward, that in 40 years of public health, I have never seen anything this transmissible and spread this quickly as Omicron has. I mean, we thought COVID in general was unusual, but this is unusual among the most unusual viruses I have ever experienced. And it came, frankly, even earlier to Georgia than we were expecting. We went from just a few cases, a handful of cases being sequenced, to many cases. And I haven't seen the CDC report for today, but I suspect we're going to be near 100% Omicron at this point, and certainly in the next couple of days throughout the state. And given that, we had to ramp up very quickly over the holidays all of our systems, whether that was our testing systems, our coordination systems, our communication with hospitals, our treatment and antiviral availability, including monoclonal antibodies. And it was a real difficult task, quite frankly, because very quickly, many of our own staff and many of our contractors that we were relying on to ramp up these systems themselves became infected. And so we were dealing, not unlike, I'm sure Mr. Hoppert will agree, not unlike hospitals around the state are dealing with. Not only is there an increase in Omicron cases, but also staff themselves calling out sick. And so I just wanted to give that background of how this ramped up so quickly, how we were able to ramp up additional test sites. And you'll be hearing about this from Dr. Rustin later in this meeting, but how even our best planning probably could not have predicted how quickly this would spread and the devastation that it would cause because of the ease of transmission and the fact that so many healthcare workers, public health and hospital workers and other medical workers were becoming ill. And with that, I just wanted to turn it over to three familiar faces, Dr. Drenzik, Dr. Millman, and Dr. Rustin, to give the background of where we are, both in our epidemiology of Omicron currently in Georgia, of our treatment options, and including monoclonals and antivirals, and how the distribution is going and what the accessibility is at this point. And finally, with Dr. Rustin to talk about vaccination and testing, because that too has been ramping up throughout all of this. And so I'll turn over to them, and then I'll close out the meeting at the finish of those presentations. Thank you.
Good afternoon, everyone. Thanks so much, Dr. Toomey, for the kind introduction. And members of the board, it's a great pleasure to be with you this afternoon. I wanted to take the opportunity to provide you a brief presentation, essentially a snapshot of the epidemiology of Omicron and of COVID in general in Georgia. And again, it's essentially an update of a similar presentation that I had the pleasure to give to you almost exactly 2 months ago. And so much has changed in 2 months, as Dr. Toomey mentioned. So we'll start with the first slide, and we'll just talk a little bit about as we start with the snapshot of the big picture of the sort of numbers that we are dealing with. So far in our response, we have documented more than 2 million cases, close to 100,000 hospitalizations in Georgia, and very near to 32,000 deaths. And again, the numbers themselves are likely and to be undercounts simply because we have a lot of at-home testing. We don't receive all of that information, and kind of with some reporting lags. But in general, sort of the magnitude of these numbers are numbing in many, many ways. When you're thinking about, as Dr. Toomey mentioned and Dean Curran mentioned, it's beyond anything that we have ever dealt with in regards to volume and magnitude, in regards to surveillance here in Georgia. So where are we now? So the last time that we were together, the Delta wave was subsiding in November. And as our Delta wave subsided, it was immediately followed by this huge surge and arrival of the Omicron variant in early December. And we have seen, not only here in Georgia, but across the nation and across the globe, the rapidity of spread and the case rates far beyond any of the previous waves in the pandemic. And as I'm sure many of you are very familiar with, there have been a number of scientific publications that are now available in such a short period of time, and the data that have come forward preliminarily showed initially that certainly Omicron is much, much more transmissible than other variants. It results in fewer hospitalizations and deaths than other variants, and that vaccine effectiveness certainly is compromised with Omicron, but that the vaccination really holds very well for severe outcomes, hospitalizations and deaths, and that a booster dose certainly does improve vaccine effectiveness, certainly not to 100%, but ranging down from 35% up to 75% as well. So the booster dose is turning out to be very exceedingly important as well. Here in Georgia, we estimate that about 97% of circulating virus is Omicron variant now. It happened very, very, very quickly. As recently as a few weeks ago, there was very little Omicron. Now it's about 97%. I just had the opportunity to take a peek at the CDC website that updates on Tuesdays. It hadn't been updated until just now, and it's nationally, it's 98% now. So and almost 99% here in region 4 in the Southeast. So that's the estimated. So essentially all circulating virus, SARS-CoV-2 virus is Omicron variant now. We have seen this remarkable, sort of Omicron signature here in Georgia, as has been the case in many states. We have seen our daily case numbers increase by more than 16 times in a month, less than a month. So from 4 weeks ago till now, we were at about 1,500 cases, and now we're about 25,000 cases a day. And that is the very typical vertical signature of Omicron that you'll see in just a minute. Next slide, please. And so our case numbers, of course, skyrocketed, and our hospitalizations have also increased. Again, they were down at a pretty low plateau to begin with. Our hospitalizations have increased, even though, we just said that Omicron may result in fewer hospitalizations and less severe outcomes than other variants. By sheer numbers alone, you're really going to get an increase in hospitalizations. So we've had about a 5 times increase in our number of hospitalizations in the last month, but our hospitalization numbers in general still, at least at the moment, are remaining below our previous waves. And essentially, we also see this is sometimes referred to as decoupling from cases. And what that means is that the hospitalization numbers are nowhere near as high as these case numbers that are, skyrocketing off the page. And our death numbers, at least here in Georgia, have really been holding steady during this Omicron surge, but these can lag, and we do see quite a bit of reporting lags with deaths as well. But so far, we really have not started to see any large increases in deaths at all, and let's hope that remains to be the case. And if we look at really kind of the population of Georgia as a whole, and you think about susceptibility, and you think about protection that vaccine affords us, at least, and particularly for severe outcomes, we have about 62% of Georgians that have had 1 dose of COVID vaccine, and we have about 53% of Georgians that are considered fully vaccinated. What we've been seeing recently, and again, Dean Curran mentioned it kind of in his opening remarks as well, we're definitely seeing increases in what are referred to as breakthrough cases, meaning we're seeing infections with Omicron variant among people that are fully vaccinated and even boosted. We saw from last week to this week, we saw about a little over 50% increase in breakthrough cases. So these are infections, but again, we're still not seeing, sort of increases in hospitalizations and deaths among individuals that are vaccinated. These severe outcomes still by vast majority are still among the unvaccinated, as has been true in a prior wave as well. And if you look at the national picture, it's entirely the same as us in Georgia. Record-breaking case rates in the last 3 weeks. And in many cases, certainly the awareness that hospital capacities are beginning to get strained too by sheer numbers. So next slide, please. So now I just want to take you on a quick tour after that, sort of overarching view. Let's just take a look at some of the epi curves and see some of the characteristics that we've been seeing in the Omicron wave. We're just going to look at the 3 main surveillance indicators. We're going to look at cases, we're going to look at deaths, and we're going to look at hospitalizations as we have in the past. So here is an epi curve of our cases, and I also put an epi curve of our PCR positivity rate just to see this. So here is again, if you could look to the far right of the graph on your left, the total number of cases, which is PCR and antigen cases together, you see this characteristic Omicron vertical signature. It's like a straight line. And again, it happened in a period of just a couple of weeks. And here we are, well over double the number of daily cases that we have ever experienced. And we're consistently seeing over 24, 25, 26,000 cases a day. Our previous peak was actually in the January wave. And we had seen a previous high of 12,000 some cases. That was our highest ever day, 12,800, I think it was. And now, again, routinely, we're more and more than double that. And that is the vertical wave of Omicron that you see. And if you look at the graph on your right, this is our PCR positivity rates as well. They also jumped dramatically during this time. Again, way, way higher than we've ever experienced before as well. Last week, our PCR positivity rates were well in the 30% range, meaning out of everyone that was tested, more than 35% of these people tested positive. So again, this is an indicator certainly of very rapid spread, of accelerating cases, but is also an indicator that more testing is needed, that we may not be capturing everybody. And so you'll hear a lot more about our efforts to increase our testing as well. And this has been similar in every other state too. Next slide, please. So if we're thinking about, I think it's always interesting as we're looking at these three main surveillance indicators, cases, deaths, and hospitalizations. If we look at and answer the question, well, who is being affected most? Which age groups are actually being impacted by these infections? So these are cases alone. And by far, we have seen throughout the entire pandemic that relatively young to middle-aged adults have consistently been the age group that is most frequently infected with SARS-CoV-2, no matter which wave, no matter which variant. It's always these folks in the blue line, the folks that are between 35 and 54. So this is also the case in Omicron as well. These folks are also comprise our most frequently infected age group. And below that, here in this Omicron wave, we're also seeing this green line, which is the 23 through 34-year-olds. So young adults to middle-aged adults most frequently with Omicron, not many kids at all, which is very different than we saw in our Delta wave. Remember, we saw a tremendous impact on school-age children during Delta, which was the green line that really came up in the previous wave. So next slide, please. Okay, so let's take a look at the deaths now. And again, the picture is a little different, right? So we have our previous waves, and in this epi curve, we're not seeing that vertical signature. We really are seeing our deaths at the far right hold steady. We're seeing just a little bit of variation from day to day. And again, vital records data often, slows down in weekend periods, and then we get some rises by midweek. But again, if we sort of look at in total, we have not seen a large increase in a number of deaths as of yet. In Georgia. This is a lagging indicator. We may begin to see some increases, again, simply because of volume of cases, by sheer volume alone in these Omicron cases. But luckily, we're not seeing large increases and surges in deaths as well, which holds well with the epidemiology of the variant itself. Next slide, please. And as was true with cases, we have seen the age group that is most frequently impacted by COVID infection-related deaths has by far been the 65 and older group. So what you're seeing here is certainly still on the far right. This is still essentially the Delta wave. We're really not seeing a whole lot of deaths in the very, very far right yet. We have not seen this increase yet, but still, those over the age of 65 still comprise the age group that is most frequently, subject to fatal infections here as well. And I think that, as we mentioned during the Delta wave, this decrease essentially in the magnitude of deaths that you see from a year ago, which is that really big peak in January a year ago, that it was prior to vaccination. So the vaccination has really made a tremendous difference in the number of deaths, even though we're still seeing, a number of individuals over 65 and older. Again, it's half of what it was a year ago, and that's due to vaccination, which is a good thing. And so let's hope during this wave, we continue to see these low death numbers too. Thank you. Next slide, please. And so what about our last surveillance indicator? What about hospitalizations? So here again, most of these P curves are all looking the same in shape. And this one too. So here we are experiencing a increase in hospitalizations during the Omicron wave, as you can see, beginning in late November and shooting up throughout December to about yesterday's census number of deaths, of hospitalizations in hospitals in Georgia, across the state in Georgia, was about 4,900. The peak number that we have ever had in a day, individuals that were hospitalized with COVID, was 6,000 on September the 7th of 2021. And that's this peak in the Delta wave. So we're not quite there to the peak yet. So we're kind of still remaining below both the January wave and the Delta wave. But again, we are seeing increases, and it's strictly a matter of, here we have, 25,000 people infected every single day. By volume alone, we're going to get individuals that again, may have comorbidities or other host factors that make them susceptible to the need for hospitalization. So we're going to have these increases, but we are not going to have, what we consider that same huge surge like we see with cases. Next slide, please. And our similar question. So who's being hospitalized? Which age group is most frequently hospitalized? And again, for the most part, as we're seeing throughout the pandemic, those that are over the age of 65 are most frequently hospitalized. Although during the Delta wave, we saw the blue line, our 35 through 54-year-olds also had very high hospitalization rates, kind of among younger people. And we're seeing that so far in this Omicron wave as well. We're seeing essentially individuals that are, again, by far the number of cases that we saw were among the 35 to 54-year-olds, and we're also seeing a similar number of hospitalizations that at least they comprise so far the largest age group. And whether that will hold as we see, sort of these lagging hospital data come up a little bit more, we will remain to be seen. But again, we're looking at these young adults, young to middle-aged, although I fall there, so I think it's young, right? All right, so let's go to the next slide. So what I've done in this slide, really just for a view, as I just superimposed all three together. So the red are cases, the blue line are hospitalizations, the green is deaths. And so this really just goes, it's not the whole pandemic. This starts in January of last year. So it encompasses the January wave, the Delta wave, and the Omicron wave now. So if you look at this, this is where you can really see this really characteristic, what we call not only the vertical signature in cases, but the decoupling of hospitalizations from cases, meaning that hospitalizations are increasing, but not by anywhere near the rate that cases are. And, we saw, as you can see in the previous waves, the blue line, the hospitalization line, is much closer to the peak levels of cases. And that is very, very consistent with, sort of how COVID epidemiology and clinical picture played out then. But this is it's a very different situation, and it's, kind of much milder. And look at the deaths are really, really low in this Omicron wave as well. Next slide. I just wanted to bring up, as we're talking about, sort of the picture of vaccination and really the picture of susceptible. I just wanted to highlight in our surveillance system, we've now documented, pretty close to 188,000 people that have had breakthrough infections. And again, it seems like a big number, but it's really not compared to the large numbers that we're dealing with. But still, I wanted to at least note that it's about a 54% increase than what we saw even just a week ago. So I think it's safe to say that this is not unexpected, but the good news is truly that we're really not seeing these severe outcomes among people that even are getting these breakthrough infections. We're really seeing the low hospitalizations, although they're increasing, they're lower, and deaths as well. So next slide. And I think this is it for me. I wanted to really just kind of summarize what we just talked about. So again, the SARS-CoV-2 Omicron variant arrived in late November, just as the Delta wave subsided, and resulted in skyrocketing, record-breaking case counts in just a matter of weeks. We saw, our Omicron wave case counts higher than we have ever experienced before, more than double. And our outbreaks are also significantly increasing during this time as well. During the Delta wave, we saw vast majority of our COVID outbreaks in school settings, among school-age children, school and university settings. And here in Omicron, at least so far in these few weeks that it's been here, it has been almost exclusively, sort of in long-term care facilities as far as outbreaks go. And, schools were on holiday break during this time, during much of this time as well. I expect to see some increases there, but this very vulnerable population, even though highly vaccinated, sometimes some of the staff members, we're still seeing some increases and some breakthrough in long-term care facilities too. Hospitalizations are rising here in Georgia, but definitely at a much lower rate than the cases, and our deaths are holding steady. So having up-to-date vaccination, and including booster, is really a strong contributor to these low severe outcomes that we're seeing. But again, we are not only here in Georgia, but in many places in the country starting to see some hospital and healthcare systems beginning to be impacted by these increases in hospitalizations as well. So again, as you've heard many times before, in order to for us to combat this and work on stopping these increases as well, clearly vaccination boosters are of primary importance. Masks when appropriate, isolation and quarantine as appropriate as well are really critical for stopping this increase. And I will stop there and thank you all for your very kind attention.
Thank you, Dr. Drenzik. We do have two more COVID presentations on therapeutics and testing and vaccination sites, but do any of the board members have a comment or question for Dr. Drenzik? Dr. Howard.
Yes, just a statement about the variation in hospitalizations across the state. As you stated, just because of the sheer number of infections, the rate of hospitalization is probably lower, but in the Atlanta metropolitan area, the Atlanta metro hospitals have already exceeded the record number of hospitalizations we've experienced in any other wave, and almost every hospital in the metro area is on some form of diversion and overcrowded. I can speak for Grady that in the previous waves, our high was 140. Today we're at 260, significantly higher. And the hospital is currently holding 103 patients in the emergency room awaiting admission.
Wow. Yeah. And it's such a good point, because you're right. And it's sort of a paradox. Like you see these, sort of low-ish, hospitalization rates compared to those high cases, but it's still higher. And I know that nationally yesterday was record hospitalization day in the entire pandemic, as well as in the US as a whole.
John, any other comments?
No, I just want to make sure everyone listening on the call understands that while the hospitalization rate is lower than previous levels, the number of people being hospitalized is significantly higher, and putting a huge burden on the healthcare system. And couple that with this being the first wave where significant numbers of healthcare employees have become infected and had to be off work, it really has been a difficult situation.
John, I think another thing that's been confusing from the news is there's been a little bit of a dismissal of this because of the practice of testing people who come into the hospital for other reasons who also have COVID. And I've always thought that was a minority of cases as opposed to a really important factor.
Yeah, the study out of New York, I think, showed that 40% of diagnosed COVID cases were admitted for other reasons. And there's been a lot of questions about how can you differentiate that. For us, it's easy to differentiate a patient who was involved in a motor vehicle accident and brought into our trauma center who happened to test positive. But the vast majority of individuals that were first diagnosed with what turns out to be an existing chronic medical condition and diagnosed with COVID, appears that the COVID diagnosis has exacerbated the chronic clinical condition, medical condition, and it's really impossible to uncouple those.
Thanks, John and Sherry. You know, the other thing is that even if they're just diagnosed with an incidental thing, it requires isolation in different healthcare facilities. So thanks again, Dr. Drenzik. Now we go to Dr. Millman for a therapeutics update.
All right, good afternoon, everybody. I'm going to be providing updates on COVID-19 therapeutics. Next slide, please. So the focus of the talk is going to really be highlighting the outpatient COVID-19 therapeutics, some of the existing ones, as well as some of the newly available ones. So to highlight the classes of medications that have been approved for outpatient COVID-19 therapeutics, we have monoclonal antibodies, which include REGEN-COV, BAM-EDI, sotrovimab. We also have a new product as well called Evusheld, which is indicated for pre-exposure prophylaxis only for certain patient populations. In terms of intravenous antivirals, remdesivir is now a therapy that is being looked at as a possible therapy for outpatient COVID-19 therapeutics. And then for oral antiviral products, there are 2 drugs available, molnupiravir and Paxlovid. Next slide, please. So when we talk about monoclonal antibodies that are available for treatment, prior to mid-December 2021, BAM-EDI, REGEN-COV, and sotrovimab were the only recommended therapies for non-hospitalized patients with mild to moderate COVID-19 who are at high risk of progressing to severe disease. Unfortunately, Omicron has numerous mutations in the spike protein and is predicted to have markedly reduced susceptibility to both BAM-EDI and REGEN-COV. At this time, sotrovimab is the only available monoclonal antibody that is anticipated to have activity against Omicron. Next slide, please. For monoclonal antibodies for pre-exposure prophylaxis, the one that I'm going to highlight is Evusheld, which is authorized for individuals who are moderately to severely immunocompromised and may not mount an adequate immune response to COVID-19 vaccines, as well as for individuals with a history of severe adverse reactions to COVID-19 vaccines and/or components of the vaccines. In vitro testing of Evusheld demonstrates a reduction in potency against Omicron. However, the clinical significance of this is unknown at this time. And as such, Evusheld is still recommended as pre-exposure prophylaxis for eligible individuals. Next slide, please. For intravenous antivirals, remdesivir is a product that is now being thought of as a possibility for outpatient treatment. So this medication is currently approved by the FDA for use in hospitalized individuals. So if it were to be used as outpatient treatment, this would be an off-label indication. However, it's now being recommended as a possible therapy by both the Infectious Disease Society of America as well as the NIH COVID-19 treatment guideline panel. So outpatient treatment for non-hospitalized patients with mild to moderate COVID-19 should be initiated with this medication within 7 days of symptom onset. And the advantage is that the treatment is expected to have activity against Omicron. However, there are a couple notable limitations. One is that treatment with remdesivir requires intravenous infusion for 3 consecutive days. Additionally, it must be administered in settings able to manage severe hypersensitivity reactions such as anaphylaxis. Next slide. And finally, for the oral antiviral products, on December 22nd and 23rd, FDA issued EUAs for both Paxlovid and molnupiravir. So treatment with Paxlovid or molnupiravir is for non-hospitalized patients with mild to moderate COVID-19 who are at high risk of disease progression within 5 days of symptom onset. Both of these treatments have activity against Omicron. However, there are some notable limitations for these treatments. One is that Paxlovid has many drug-drug interactions, and it also needs to have dose adjustment for certain medical conditions. Additionally, molnupiravir is not recommended in pregnancy or in children. Given these limitations with these medications, there needs to be a clinical assessment that is done prior to prescription. And per the EUA, only physicians or advanced practice practitioners are authorized to prescribe these medications to patients who have a positive COVID test who meet the eligibility criteria. Next slide. I want to next highlight some issues related to availability and supply challenges. So right now, the availability of monoclonal antibodies and oral antivirals are extremely limited nationally. Georgia receives allocations of these products from HHS that we then will distribute to enrolled providers. On the 10th of January, we received our most recent allocation numbers. For sotrovimab, there were approximately 1,180 treatment courses that were made available for this 1-week allocation cycle for the entire state. For Evusheld, there is approximately 2,200 courses for this 1-week allocation cycle for the entire state. And for oral antiviral products, both Paxlovid and molnupiravir combined, there are approximately 12,460 treatment courses that have been available to the state for a 2-week period for this allocation cycle. There are also some courses of BAM-EDI and REGEN-COV that have also been made available for 1-week allocation cycle during the January 10th allocation. One thing that's very important, though, is that providers must report their usage and inventory to HHS. Accurate reporting is critical as this affects what our state's future allocations are. So for any providers for any of these medications, please make sure that you are reporting your usage and inventory to HHS as required, because this could affect the allocations that our state receives as a whole. Another important note is that the allocations are not expected to increase significantly prior to the end of January. Next slide. So to just give you a sense of where our providers are for monoclonal antibodies for treatment, there's been operations in the state that have been ongoing for a number of months already. We currently have 325 plus enrolled providers located throughout the state. The process for placing order requests has been in place since September, when HHS placed all jurisdictions on allocation. Although all products have been available in recent allocation cycles, HHS has indicated that BAM-EDI and REGEN-COV allocations may be paused in the future when Omicron proportion exceeds 80% in CDC nowcast model. I know that this has happened already and we have not had an allocation pause, but I did want to just highlight that it is possible that there may be a pause in allocations for those products in the future. For Evusheld, our enrolled providers include regional coordinating hospitals and several institutions with large populations of immunocompromised patients. And eligible patients can be referred to those centers for treatment with Evusheld. Although Evusheld has been received by multiple institutions, there are some that are still working on their protocols, so they may not be offering it to patients quite yet as they're just trying to finish up their protocols, but those should be available soon. So for people that are interested in getting that medication who meet the eligibility criteria, it would be important to contact one of those institutions ahead of time. And finally, for remdesivir, fortunately, there are sufficient supplies of this medication that it is not on federal allocation. It is currently available for direct purchase for healthcare institutions. Next slide, please. For oral antivirals, Per HHS guidance on managing our limited initial allocations, the Department of Public Health has partnered with Walmart, Walgreens, and Good Neighbor Pharmacy Group, which is a group of small independent pharmacies, to ensure that we have statewide coverage. Several factors that were considered in identifying locations included geography, vaccination coverage, social vulnerability index, access to other COVID-19 therapeutics such as monoclonal antibodies, and the ability of the pharmacy partner sites to be able to accept that initial order. We are also working with these pharmacy partners to onboard additional pharmacy locations in other areas that are not served. So this continues to be a work in progress. As allocations increase, an ordering process will then be made available for other therapeutic partners interested in dispensing these products. Next slide, please. This map, which is available on the DPH webpage, shows locations that have received shipments of oral antiviral products. It is something that we can that has been updated with additional pharmacy sites since it was originally posted. I would also just like to note as well that HRSA has a program with a separate allocation process, and there are 2 HRSA FQHC sites that are in our state. One of them is in Atlanta, and the other one of them is in Swainsboro. But that is outside of the DPH allocation process. Next slide, please. I would also just highlight the links here to help individuals who are interested in locating where treatment providers may be. For monoclonal antibodies, HHS has a therapeutics finder tool that patients or physicians or providers can use to try to identify where monoclonal antibody providers are. And for Evusheld and oral antivirals, HHS has provided a public therapeutic locator. Please note that these show where facilities have received shipment. It may not necessarily indicate that there is supply on hand at that time, so it is still a best practice to check ahead of time before writing a prescription at one of those institutions or as a patient going to one of those institutions to try to get therapy. Next slide, please. I would like to also just share from the NIH treatment guidelines panel usage guidance that have been developed for supply constrained settings. So when logistical or supply constraints exist, the NIH panel recommends that clinicians prioritize their use of these products for patients who are at the highest risk of clinical progression. They've divided up into 4 different tiers, with tier 1 being those who are at highest risk for severe COVID illness, which includes individuals who are immunocompromised, not expected to mount immune response to COVID-19 vaccination, and regardless of what their vaccination status is, or for unvaccinated individuals at highest risk of severe disease. And then you can see the risk groups going down otherwise. So especially in these supply constrained settings, and we have shared this information with therapeutics partners, please do consider these given the very limited number of supplies that we have available in the state to make sure that these are going to the patients who are at highest risk for severe outcome. Next slide, please. The NIH treatment guidelines panel has also made recommendations as well. So for non-hospitalized patients with mild to moderate COVID-19 who are at high risk of disease progression, the panel recommends using one of the following medications: Paxlovid, sotrovimab, remdesivir, or molnupiravir. While there are differences in the medications, given the supply constraints that we do have, really the medication that is available, as long as it is not contraindicated in an individual, is the one that is going to be able to provide the most benefit for patients who are at high risk for disease progression. Per the HHS Therapeutics teams, institutions that do have the capability of differentiating Omicron versus Delta, for example, there are some assays that may be able to detect the S gene target failure. It's like institutions such as that may consider using that information to determine if an individual patient would benefit from the use of Region-CoV or BAM-EDI. If institutions do not have that and they are using those products on patients, it is important to have a discussion with those patients about the effectiveness data related to Omicron for those products in an effort to have shared decision making about the use of those products in those patients. Next slide. So to summarize, new treatments have become available for treatment of mild to moderate COVID-19 in non-hospitalized patients. The supplies of these products are extremely limited and not expected to increase in the near future. And as such, based on guidance from NIH treatment, the NIH COVID-19 treatment panel, patients at highest risk for severe COVID-19 should be prioritized for treating in this setting of limited available supplies. Vaccination and boosting remains the best and most widely available tool for being able to prevent severe illness and death from COVID-19. Next slide. And thank you. I'll take any questions.
Thanks so much, Dr. Millman. You must be a very popular man right now. And I think just even though the drugs aren't available as much as we want them, it does take me back to the AIDS era again and think about the progress that antivirals have made in the last 30 years. And to remind us that actually Paxlovid contains ritonavir, which began its life as an anti-HIV drug and is used as part of the cocktail for COVID. So it makes us very optimistic, I think, about where we're going to go with therapeutics against this virus if we could just slow it down a little bit until we can get there. Any comments for Dr. Millman or questions? Thank you so much. Now we're going to go on to testing. Dr. Rustin.
So thank you, Chairman Curran and the board members. Dr. Toomey, it's always a pleasure to be in front of you guys and present to you all. Today, I'm going to talk about vaccination and testing. I have a lot of updates since I've spoken to you last. And so next slide, please. What this particular slide is demonstrating is where we are currently in our vaccination efforts. The screenshot from our website yesterday shows that right now we've administered over 13 million doses of vaccine, but we are at 61% of Georgians with at least one dose and 53% or 5.5 million of individuals that are fully vaccinated. Obviously, there's still a lot of work to do there, and we continue our vaccination efforts and promotion of getting vaccinated every day. We've added a few additional features. We've added the additional dose, so you can see over 1.9 million Georgians have received an additional dose. And right now, approximately 34% of individuals who are fully vaccinated have received an additional dose or their booster shot. I've also broken down kind of a pie chart of the number and types of vaccines that we've administered. Over 7 million vaccines have been Pfizer vaccines. The new pediatric version of Pfizer, the 5 to 11-year-olds, as of yesterday, we had administered over 250,000 doses, or about 2% of our overall vaccines administered. Around 5 million Moderna doses and around 2% or 311,000 Johnson & Johnson or Janssen doses. The last information that I'm presenting again is an update on the age groups of individuals vaccinated. And as you can see, we've done a phenomenal job of folks 55 and older receiving at least one dose of vaccine. But again, there's opportunities in the younger categories. The adolescents are at 36% and 51 to 60% up through age 44. And so again, we continue to work and encourage individuals in those age groups to get vaccinated for this virus. Next slide, please. The last time I presented, I kind of gave some overall statistics on our providers. What I wanted to show today is sort of a breakdown of our major providers to give everyone an idea of how many providers that we have in sort of the major categories. Under our public health providers, we have 198 local health department public health clinics offering vaccine in Georgia, 106 federally qualified health centers, and 9 rural health clinics. 162 hospitals are offering vaccine. And then under our medical provider, you can see the breakdown. We have the majority is in the family medicine category. We have 116 internal medicine practices, 25 OB-GYNs, 240 pediatricians, and then the other specialties are the other various medical specialties at 249. Our largest category continues to be pharmacies. As you can imagine, in the beginning, the federal government prioritized pharmacies due to their footprint in the country. In Georgia, there's currently 937 chain pharmacies that are offering vaccine and 327 independent pharmacies, which you typically find in your smaller towns and rural areas. We continue our outreach efforts with the medical providers to enroll more pediatricians, to enroll more providers. I think we all feel that individuals typically trust their medical home or their medical provider the most for medical information, and we continue to encourage providers to enroll and offer this vaccine. Lastly, we have a partnership with our mobile vendor, our mobile vaccinator, Core. They continue to offer various clinics throughout the state. These are usually smaller clinics, but they're able to go into communities and target areas where we know individuals need to be vaccinated at, and they've been a very important partner for us throughout this pandemic. Next slide, please. The reason I wanted to provide kind of an update on the current vaccines distributed, as you can imagine and remember, in the beginning of this pandemic, Pfizer was our first vaccine, and it was offered in very large packaging, 1,150 and 450 dose packaging. This created a barrier and a challenge for a lot of small providers because they could not handle that large a volume. And during that time, the vaccines required special storage. You had to have special ultra low cold freezers to store this in. Dr. Toomey and I and others have talked repeatedly to the federal government about reducing the increments and the size of doses packaging. And finally, the vaccine providers have caught up with that, and they've started sending out much smaller dosage packaging. The current Pfizer Tris brand is for 12 and above. This is a fairly new product that comes in 300 dose increments. And the good thing about this product is it doesn't require diluent, which means no mixing. The Pfizer 5 to 11-year-old comes in 100 dose increments. Again, this makes it much more easier for pediatricians to utilize in their small practices. And the other thing that Pfizer has done is through their stability studies, they're allowing these vaccines to be stored at normal laboratory grade refrigerated temperatures, which makes this much easier for these smaller providers who don't have the ultra cold freezers to store this vaccine. Moderna offers in 100 dose increments, and that's for 18 and above only. And then our Johnson & Johnson is 18 and above in 100 dose increments. We still have some of the large dose packaging out there, the 1150 dose as well as the 450 dose in our inventory throughout the state, but we're slowly working down that inventory, and all the new products that I've mentioned is what's currently being ordered now. Next slide. COVID boosters. We've had a lot of, if you've kept up with the news and the updates from FDA and CDC, they've made a lot of tweaks and changes to booster recommendations. In the last week alone, Pfizer is recommending, CDC is recommending that anyone 12 years and older who received their primary Pfizer series get a booster 5 months instead of 6 months after their initial Pfizer series. One thing I do want to remind everyone is that Pfizer is the only vaccine currently approved for children. For moderately or severely immunocompromised individuals that are 5 to 11-year-olds, Pfizer has submitted an EUA request that was approved, and CDC recommends those individuals get an additional dose 28 days after their second shot. Moderna is for anyone over 18 years or older. They're also recommending now a booster for those 5 months instead of 6 months. And there's been no change in the Johnson & Johnson. It's still recommended to get a booster shot 2 months after the initial Johnson & Johnson series. So we've been working to put out additional education on this, and all of our health departments are currently following these recommendations as they're administering the vaccine. Next slide, please. Long-term care facilities, as you may remember, in the beginning of this pandemic, the federal government partnered with long-term care facilities to provide essentially through Walgreens and CVS partners to provide the initial vaccine series for the individual residents and staff that live in these facilities. For boosters, the CDC as well as the department has been working with the Georgia Healthcare Association to partner long-term care facilities with various providers that can provide booster shots. The things that DPH has done in addition to partnering with Georgia Healthcare Association is we've sent a survey out to all the long-term care facilities that they can complete if they need assistance with connecting them with a booster partner. We've also contracted with a vendor that's available to provide booster shots in long-term care facilities, in addition to our local health departments that are doing that as well. Based on our survey results, long-term care facilities primarily have connected with our local health departments, various pharmacies, our DPH vendor, as well as their own in-house medical providers. Just to give you kind of a snapshot of where skilled nursing facilities is in booster vaccination, and this is based off of CMS data that was published on January 5th. Residents that live in long-term care facilities that are skilled nursing facilities are at 66.5% boosted. And as you can see, the staff are at 26.6%. So there's still a lot of opportunity to get those residents boosted, but more importantly, to get staff and encourage them to get boosted because the staff is the ones that can bring it into the facilities and are much higher risk of bringing that in. Next slide, please. On the last call that I presented, we talked about our small packaging updates. This was as a result of the large Pfizer packaging. One thing that I'm very proud of that our agency kind of led, I believe, the country in is developing this process to repackage the large packaging Pfizer into 120 dose and 60 dose packaging. We did this because physicians were requesting smaller doses, and at the time the manufacturers weren't providing smaller doses. Our small dose packaging. Now that the providers are providing those small dose packaging, we are only offering this under an emergency request. Our warehouse team is available to do this for emergencies, but we are directing providers to order directly through our system, and they can receive much smaller packaging from the manufacturers. But just to give you some statistics, our team at the warehouse was able to provide small dose packaging to 176 providers. We conducted over 876 shipments, and to break that down, we shipped out over 87,000 doses of Pfizer adult as well as the Pfizer pediatric. And so the team, when they were asked to come up with a process to do this, they definitely rose to the occasion and made us all proud in ensuring that we could provide this smaller dosing packaging to providers. Next slide, please. For our jails and correctional facilities, as I'd mentioned on the last call, we contracted with a vendor to assist us with prioritizing vaccinating in jails and correctional facilities. And most recently have added that testing to that same vendor's contract to offer testing within jails and correctional facilities. Currently with our vendor, they have provided vaccinations in 142 jails or correctional facilities and have administered over 35,000 vaccines of all the different products. This breaks down to over 13,000 first doses, 10,000 second doses, 3,500 additional doses, and over 8,000 booster shots. And they continue to offer this to jails and correctional facilities around the state. I connected a jail yesterday to our vendor that's going to be enrolling and also offering testing for that particular jail. And so this is just a service that we're offering to the jails and correctional facilities. Next slide, please. One thing I didn't mention earlier is that we've had a state COVID call center since early 2021. We've had a turnkey vendor on hand that has been operating our call center. It's a virtual call center. We don't have 100 people in a room. They're all over the place. But on average, we have about anywhere from 97 to 100 call agents at any given time. That's open 7 days a week, including holidays. These agents are able to answer general questions related to vaccines and boosters, or they can refer people who call in to various subject matter experts like the Poison Center. Our agents also can assist with scheduling vaccine appointments. We recognize that not everyone has access to internet, and they can call this number and they can be scheduled for an appointment through our call center. Just a few statistics. Since we put this call center in place, they've handled over 346,000 contacts. This is kind of broken down into 266,000 calls. And they're able to tell me exactly how quickly they can pick up those calls. Over 98%, almost 99% are picked up within 8 seconds. Over 59,000 of these are outbound outreach calls. What this means is that if someone called and left a message, they call them back to help them with whatever their questions are, or if they need an appointment. They also have a chat system, and they've conducted over 10,000 chats, and they've been able to have over 9,400 individuals that have reviewed articles related to those chats. Next slide, please. Testing, as this has been obviously in the news all throughout the last few weeks, is having access to testing across our state. Since December 1st, the Department of Public Health has operated 163 testing sites. We call them SPOCs, specimen point of collection sites, that are either managed by our local health departments or through our contracted vendors. Since the Omicron variant has increased, we've been ramping up sites as fast as we possibly can. Our various vendors are Mako Medical. They have currently over 58 sites with 362 staff assisting. LTS Laboratories has 35 sites with 268 staff. And we recently brought on Viral Solutions. They have had several private sites set up around the metro region. We brought them on. They helped us stand up 2 sort of large mega sites in the metro region recently, one in DeKalb and one in Cobb. And we're working to stand up a 3rd large site very soon. Since the Omicron variant, we've been working hard to stand up various surge sites. We've stood up 7 surge sites in the last couple of weeks. And just to kind of put this in perspective, you could see on the right, in the last 7 days, this is just public health. This isn't private testing facilities. In the last 7 days across the state, the Department of Public Health, either through health departments or through these contracted vendors, have collected over 70,000 testing specimens. The majority of those have been swabs that are sent off for PCR testing, and some of those have been rapid antigen tests. So it's been very busy, as we all know. And we continue to work with our vendors, with our health departments, and with our community partners to identify additional sites and stand up more testing sites as quickly as possible to help provide more opportunities for free testing to our citizens. Next slide, please. Rapid test. This obviously is a hot commodity, very high demand for rapid tests. And unfortunately, there's a shortage of these supplies across the country, as you can imagine. The department has been working with all of our supply chains. We've been researching various suppliers, and we're purchasing rapid test supplies as fast as we can find them and as they become available. To date, the Department of Public Health has distributed almost 1 million rapid tests to our local health departments, long-term care facilities, shelter confinement facilities, our EMS fire agencies, hospitals, mental health facilities, and colleges. We've tried to prioritize where we are sending those rapid test kits to make sure they're being used for the most good across the state of Georgia. But we do continue to look for supplies. This is something that's, again, in short supply. But as we order supplies, we continue to send these out to our various partners to be able to utilize. Next slide, please. I'm going to end my presentation with this program. This is something that is fairly new. We've rolled it out over the last few months. The Department of Public Health has a school testing program for school systems. It's for our K-12 schools. This is for any school in the state of Georgia. Any K-12 school can enroll with the department. We have testing vendors lined up that can provide COVID testing free of charge for all students, faculty, and staff. And most recently, we were approved to offer it to family members as well. Right now, we currently have 103 school systems that are enrolled in our program. Since January 1st, we've enrolled in 10 additional schools. We currently have 17 schools that are working on the memorandum of agreement with the department, and 19 schools are working on developing their profile with the labs. We wanted to mention this because we wanted to get some attention. This is a service that we're offering to schools free of charge. This is based off funding we received from the federal government, and any K-12 school in the state can enroll in this and offer. And there's all kinds of different programs that the testing vendor can tailor for that school. The department's happy to talk with any school that's interested in enrolling. And we do provide this as a service to schools because we certainly recognize it's important, for children to be in school and for it to be a safe environment for everyone. And with that, I will be happy to take questions. Next slide.
Thanks a lot, Dr. Ruskin. It's an enormous task that you've undertaken and done successfully. I have one question about, as I mentioned before, I started the thing saying that I had a good chance of getting COVID. Even though I'm in the vaccine trial at Grady, I've actually become quite a popular person in that vaccine trial. I get called every day. A breakthrough infection in a vaccine trial is like owning a piece of gold. So my saliva is valuable. But the thing is, what I'd like to say is that when I went to get my tests at Viral Solutions, I could just give them my insurance card and it was free. And pretty soon the rapid tests are going to be free from private insurers. Is there any way that the public health agencies can participate in getting reimbursed through private insurance for either testing or soon vaccines or soon antivirals?
So I can't speak to antivirals, but for the vaccines and testing, the public health departments, like any other medical provider, can bill insurance or can bill the HRSA program, which is a federal program for the uninsured. But the one primary message that I want to make sure everyone understands that's listening is that our testing is free, regardless of insurance status. We don't require insurance. If you have it, we will request it for billing purposes, but it's not required, and no one will be turned away from testing or vaccine sites for that purpose.
All right, and it sounds like the rapid test will also be covered by insurance as well. I mean, it could be quite a large amount of money to be reimbursed for. And it's important not to say that it's free, but if half the people have insurance, it could save a lot of money.
Yes, sir.
Any other comments or questions? Dr. Toomey, we had 3 outstanding lectures. I wish the whole country could have heard these and learned so much and so clearly. But now the floor is yours.
No, thank you so much, and many thanks to the team. I hope that this gives you a snapshot of what we've been doing really since right before Thanksgiving as we began to ramp up our efforts. It has been challenging in ways that I think you've alluded to, Dean Curran, but that hasn't been perhaps explicitly stated. There's a lot of myths about Omicron, and you see it every day in the paper. It's not serious, it's less severe. The vaccine doesn't work, so why should we bother getting vaccinations? And which is really a challenge for us because we still know we need to get additional individuals with primary vaccination as well as boosters. That there's plenty of treatment, and as you saw from Dr. Millman's presentation, with 25,000 cases a day, and those are the cases we can document, because remember, anyone who uses a rapid test or anyone who doesn't get tested will not be reported to us. So these are just the tests that we have reported to us. There's simply not sufficient antivirals or monoclonal antibodies that are effective against Omicron available to serve everyone who may need that or who may benefit from it. And so relying on that as your fallback, is not the best prevention strategy. The other thing is that we had assets last year that we don't have now. As Dr. Rustin alluded to, for example, we had millions of rapid tests given to us by the federal government. Now we are competing with other states and the federal government to purchase rapid tests that are not easily available. And they're clearly in demand and very easy to use, and could be a benefit even to release individuals from isolation potentially. But we're having a hard time getting sufficient tests to share broadly as we had been able to do before. The concerns I have about the incoming federal program that requires you to register at a website to get these tests sent to you is that not everybody, just like with our vaccination scheduling, not everybody has access to a website. Not everybody is agile on the internet or has time to do that. And in several meetings with the White House task force, I have requested that they consider using ASTO and the other state health officials like myself to be a conduit for distribution of some of these tests, because we work in some of the highest risk communities. We have a long history of distributing and reaching these high risk populations that we could help and really benefit the federal government in their desire to reach everyone with access to testing. Those are just a few of some of the things that I think we are struggling with every day. I also wanted to say that as Chris talked about the schools, we have a new administrative order that's on our website. I'm very much a booster of ensuring that, so to speak, ensuring that children are in-person learning, because it's so critical, I believe, for all children to be able to have that kind of educational experience. I have, as I've talked about many, many times, I got my education in the public school system in Western Pennsylvania, and I really feel so strongly that we have to make every effort possible to ensure that children can safely remain in schools and that teachers and the other staff can safely remain in schools. And so we have posted our new administrative order. It parallels the isolation guidelines that CDC has published. It was a little bit misrepresented in the press because the isolation and quarantine seem to have been kind of mixed up, and there is a lot of confusion. Isolation is when an individual tests positive. The isolation for an asymptomatic individual who tests positive and is in the schools. So teachers, bus drivers, cafeteria workers can come back to work in 5 days with a mask. So that is expected that a well-fitting mask will be part of that then 10-day regimen. On the quarantine side, that's when someone has been exposed, whether in school or outside of school. Our administrative order is a little different in that we are considering schools as critical infrastructure. And so even if unvaccinated staff are exposed, we are saying that they can return if asymptomatic, only if asymptomatic. And again, wearing a tight-fitting mask for that 10-day period. And so I sent that administrative order to the board so that you could review it and see, and really want to thank the governor and his team for his support, not only for the school opening, but also for promoting our testing program, which I think can really benefit the schools because of our ability to test all comers, not just students, but faculty, other staff, and relatives of family members of everyone who touches the school. And we have not had the uptake that we had hoped, but we really do hope that with this awareness and the availability, that this service from us that will not require input from the schools themselves, other than identifying a location for us to work, will be important. The final thing I wanted to say is there's also been some recent discussions in the press about our vaccine and vaccination reporting system, our case reporting system. Many of our public health systems, most of our public health IT systems are legacy systems that were never, ever designed to handle millions of data points. And what's happening is we're having difficulty having those old systems respond to the surge. And we are working and have been over the last year to have a new system that will really meet the needs not only of this pandemic ultimately, but future pandemics, but that will take a while for those systems to be put in place. But I just want you to be aware that this problem of legacy systems has been trailing us since the beginning of the pandemic in 2020, and it has other states as well. And this is part of that public health infrastructure that I think from the very beginning was seen to not be up to the task of responding quickly in an agile way with the ability to communicate across all sectors, not only of the medical community, but also to the public. And we are very much making that a priority for us throughout this pandemic, and especially now. And last, I just wanted to recognize not only the three individuals who spoke today, who have been in some of my right-hand people throughout this response, but every single public health person here at the state, at the districts, in the counties, because they have just been working beyond their capacity throughout this pandemic, but particularly now during this surge, at a time when we, like everybody, thought that we were nearing the end and we were seeing the light at the end of the tunnel. That has not been the case, and they have risen to the occasion, and we are working together as a team. And I cannot thank them enough for what they are continuing to do to protect the state of Georgia as we continue to fight this pandemic. And hopefully, as this becomes an endemic illness or whatever finally unfolds, I'm waiting for you, Dean Curran, and your colleague, Tony Fauci, to tell me to be Nostradamus on this. But whatever happens, I think that public health has shown itself to be an extraordinary leader in health in Georgia. And I just can't thank them enough, all staff at all levels, for the work that they are doing and will continue to do till the end of this pandemic and beyond. And one final comment, I think that it, particularly seeing that how these underlying health conditions do lead to poorer outcomes for hospitalized patients, for individuals in the community, whether vaccinated or unvaccinated. If ever there was a glaring example of why public health and their work on the social determinants of health is even more important now than ever before. And I like many of my public health colleagues across the country, we are anxious to get back to some of the core actions of public health in the community to address those social determinants so that we don't see these health disparities and don't see that impact of chronic health conditions that do make COVID even worse in some communities, in some areas, and to some populations. And so, having said that, again, thank you to everyone, and thank you to the board for your support throughout this pandemic.
Dr. Toomey, I'd like to thank you and also thank the staff again, and just say that I think you and I know that public health is usually unappreciated except during pandemics when it's largely criticized, but it's still underappreciated. And the amount of work that's done is being done because people are so dedicated to doing it. We've seen in society that a lot of people just don't want to go back to work. They feel like they're underpaid. We have a staff shortage throughout the world. And that's going to be true in healthcare, of course, and also in public health. But we knew ahead of time that people don't go into public health largely to make a lot of money, but there is a limit. And the limit is the extraordinarily low salaries paid at the state and county level in Georgia and throughout the country. to people in public health. And we should know now that the next epidemic is just around the corner, that we need to have not only great data systems, but we have to have people with the talent to use those data systems and the talent to supervise the people in the field. And they have to be appreciated. And one aspect of appreciation is a higher salary scale. So I've seen it every place I've worked, and it needs to happen in Georgia. So I would encourage all of us to go home and preach to everybody we can at the city, county, and state level that the salaries for public health people need to be much, much higher, and they need to be appreciated. And I think that that would go along with certificates of appreciation for the amount of work that's been done. And of course, it's true for many people in the healthcare system as well. But public health people in particular are underpaid. And I think that we need to do something about this because we recognize that as states and counties and the economies get a lot better, we need to invest in the people to get the work done, not just the hardware and software, but also the people. So thanks a lot to all of you, and thanks to the board for your attention, and we'll see you guys on February 8th.